evening to colleagues in the Asia Pacific region. Good afternoon to colleagues in the European Union and African subcontinent. Good morning to colleagues waking up in the United States. My name's John Balbus. I'm a senior advisor for public health in the director's office of the U.S. National Institute of Environmental Health Sciences, also the director of our WHO Collaborating Center for Environmental Health Sciences. And it's my great pleasure to welcome everyone to webinar WS405 of PMAC 2021. And this webinar is entitled Dealing with Disasters Fast and Slow, Health System Resilience for COVID-19 and Climate Change. Health system resilience can be thought of as the ability to prepare for, manage, either absorb, adapt, and transform, and to learn from shocks. And if there's one thing that 2020 has held for us, it's been a lot of shocks between the COVID pandemic and repeated natural disasters in many parts of the world that are climate related, like hurricanes and wildfires. There's a cycle that goes with this. There's a cycle that can be defined as starting with preparedness. There's the shock onset and alert. There's the shock impact and management, and then there's recovery and learning. And we're in various aspects of that cycle of management and recovery and learning now around the world from all these co-occurring stressors. One thing we've learned this year is that many health systems around the world are not as resilient as we had thought they were. And we've also seen that many health systems may not be prepared for the co-occurrence of simultaneous disasters, such as we've seen where we have acute disasters superimposed on a long-term pandemic. Those of us who've been working on healthcare system resilience for climate change have often focused on the resilience of the buildings themselves, their power systems, supply chains, the ventilation systems if there's wildfires, the heating and cooling systems. And one of the things that we've learned that we need to do, and in part through the COVID pandemic, is to be able to do a better job of surveillance, monitoring, and keeping an eye on data to be able to better predict either when natural disasters may be occurring. And I think there have been a lot of discussions in the PMAC conference about using data to better predict when there could be disease spillover or the emergence of new infectious diseases as well. So what will it take for us to be able to build back better? What will it take for us to get to that fourth cycle of evaluation, learning, transforming, and making health systems more resilient? To help us explore this question, we have assembled a really outstanding group of speakers. We'll have two different sessions. The first will be focused on the very latest in guidance and resources for health system resilience for climate-related disasters. We'll hear from speakers from the WHO and the WMO. And then the second session will offer a panel discussion of experiences with simultaneous disasters in the setting of COVID, as well as resources for facilitating the conduct of research during the response phase of disasters in order to better build the evidence base for the best practices in resilience. So with no further ado, I'd like to start our first session and introduce our very first speaker. He's Dr. Carlos Corvalán. He is an adjunct professor at the School of Public Health in the University of Sydney, Australia. Dr. Corvalán had a long career at the World Health Organization and continues to work very closely with the World Health Organization, especially in the subject he will be talking to us about, which is the providing of guidance for healthcare facility resilience and healthcare system resilience in the setting of climate change. Dr. Corvalán, I turn it over to you.
Thank you very much, Dr. Balbus, for this kind introduction. So first of all, I'm going to start sharing my screen, and while I do this, I'll start explaining that this is work that was done very recently and launched by WHO a bit over a month ago. So what you're receiving now is something very, very new. So the title of this is Climate Resilient and Environmentally Sustainable Health Systems, with a special focus on healthcare facilities. And this is the cover of the document. And the goals of this report is to increase the climate resilience of healthcare facilities to protect and improve the health of their communities in an unstable and changing climate, while optimizing the use of resources and minimizing the release of waste by becoming environmentally sustainable. And I'm going to explain a little bit later what this means, but most important as well is that the objectives are really to help professionals in all type of healthcare facilities, large and small, to work to anticipate and manage and adapt to health risks associated with climate change, to work with other sectors because the health sector cannot tackle all this on its own, and also to learn of some tools in order to make this assessment that this guidance provides. So what you see in this picture, it's a healthcare facility that was destroyed because of a river that got flooded and there was some erosion. And what is really interesting here is that what you can see is possibly some health workers or health workers that were not able to get to the facility because there was a flood somewhere else. You probably have a problem of no access to water. The water was turned off because the tubes are broken, pipes are broken. Very likely that they don't have energy. And also, obviously, the whole infrastructure of the building has been affected. So I just mentioned 4 key areas. And in fact, these are what we call the fundamental requirements that health and environment should be working on so that healthcare facilities can keep on functioning. And this comes out of what you've heard, this operational framework for climate resilient health systems, which was prepared by WHO in 2015 with all these elements that you see on the left. But what I want you to focus on is that round circle on the right, because these are the elements of the whole work. So we extracted from that the key parts that were very relevant to climate resilience and environmental sustainability in healthcare facilities. So to explain this a little bit better, we have on the one hand the health workforce, and we're requesting there is to have adequate numbers of skilled human resources with good, decent working conditions, informed, empowered to respond to all types of environmental challenges, specifically climate change. We need to have as well sustainable and safe management of water, sanitation, and healthcare waste services. We need to have sustainable energy services, and of course, most importantly, infrastructure, technologies, and products, ensuring that these are functioning for the healthcare facility. And this includes things like the equipment, the buying, the products that you need for the hospital or healthcare facility to function, etc. So to put it all together, including the very early definition of what we're talking about, you have in this diagram healthcare facilities in the center, highlighting the health workforce, water, sanitation, hygiene, and healthcare waste, energy, and infrastructure, technologies, products, and processes. On the left-hand side, you have the impacts that could come from climate change. So this would be the hazards. So climate-related hazards include floods, drought, fires, storms. Temperatures of extremes could be hot or cold, sea level rise, and also the outbreaks of climate-sensitive diseases. So all this is adding pressures to the problems that healthcare facility already have. So if we think in many developing countries, healthcare facilities already suffer from lack of energy, having regular electricity, for example, or not having water available 24/7. So there's a real problems happening today. Climate change brings all these additional pressures. So in front of these pressures, we need to build climate resilience. The other side of this diagram is what we call the environmental impacts, and when the idea of environmental sustainability comes from. So the issue is that a healthcare facility will affect the local environment through the waste that they produce, the air pollution, the chemicals they may release. Sometimes there could be radiation. And of course, healthcare facilities in their functioning, they also produce greenhouse gases. And then what you have here is this process of going back, greenhouse gases affecting climate change, etc. So this is the framework that we're using for building climate resilient and environmentally sustainable healthcare facilities. And Dr. Balbus actually talked about this, and it's really important to repeat it to understand it really well. So this is what we understand by climate resilience in healthcare facilities, but this is really climate resilience or resilience in general. So you have a situation, in this case, it's a healthcare facility capacity level, but could be something else. And this facility is working at its normal level, and it should continue to work at its normal level, except that in this case, something happened. And what happened is either a shock, which could be in the form of a sudden event like a flood, a storm, or a stress, which is a slow onset event, which could be, for example, a drought. What is important is that it gets to this point here in which everything reduces the performance of the facility. So you have this performance drop. And the performance drop will depend on many things, will depend on how vulnerable the facility was to start with. Even before the event, the healthcare facility could have been very vulnerable. The strength of the hazard is very important, and also how exposed was the facility to that hazard. So to explain this better, you may have a hazard in one place, but for pure luck, the facility is in a place where it doesn't get exposed, or the vulnerability is so low, so they are very resilient, and therefore the risk is not large. And this is what we're really trying to explain here. So after going through this performance drop, many things can happen. So the worst case scenario is that the facility or the whole system collapses. But what we really wish for it to happen is that it recovers to the pre-event state better than before, or as Dr. Babos used the word, transform. So we rethink the whole system as we're doing now with COVID-19, and we want to build back in a very different way, build back better. And that's what we call the transformation. So in order to continue with the same idea, this is what we understand by environmental sustainability, which we're reducing the risk in healthcare facilities by reducing the hazards, for example, the production of healthcare waste, chemicals, radioactive materials, wastewater, air pollution, greenhouse gases, etc. And then we come down to a sufficient level so that the hazards are very low. But we also need to work simultaneously in reducing exposures and reducing the vulnerabilities, both in the healthcare facilities and in the communities that these healthcare facilities are working on. So this is what we call interventions for environmental sustainability. And the whole idea is that we go from this as image in the left, in which we have a very large risk because we have high hazard exposures and vulnerabilities, to this figure on the right-hand side, in which we manage to somehow reduce these three elements, hazard, exposures, and vulnerability, and therefore our risk is substantially reduced. So just to give you an example of what we did many checklists. So the healthcare facility, I'm going to show one in a minute, they can see where they are. And we divided everything into different elements or objectives. In the case of health workforce objectives, we have things like human resources, ensuring that facilities have the good number of health workers, working in good conditions, that they are well trained and informed, that there's sufficient awareness, and that they're able to communicate among themselves, to other sectors, to patients, to visitors, etc. And then we proposed a framework in order to at least start working on establishing a baseline and eventually starting to reduce the problems that the healthcare facility would have. So the whole idea is the following. You need to start with awareness, political commitment, community engagement. You have to assemble and train your team. Then you move to the baseline. Then you move to define what is it that you can really do, because you cannot do everything at the same time. You develop your improvement plan. You monitor and evaluate the improvements, and off you go to tackle something else. If you can tackle everything, great, but often we know it's not possible. So we prepared several dozen interventions that are samples for countries to look and choose from and adapt to their local realities. And this is just to give you some examples of how this document is assembled. There's a different project that we're advancing on now, and which is to take the hazards from climate change and come up with understanding better the vulnerabilities, the resilience, and the impacts. And this is a new framework, which we call a framework to assess climate change impacts and vulnerabilities in healthcare facilities. And the idea is to help identify this in a separate set of checklists and advance towards reducing vulnerabilities. So this is more or less the way that we understand it. So you have a huge risk because of your hazards, your vulnerability, your exposures. If you manage to reduce these, then you end up with a smaller risk. And then because you cannot reduce everything at the same time, you end up with a figure that is slightly, not exactly like a cube, but it shows more or less that you can act on certain things, especially say, for example, vulnerability, and improve things. So this is the overall scheme, but I know that I'm running out of time. So I'm going to just show you this. You see, I already explained part of this before, but the objectives of this new work is to assist healthcare facility managers and staff to identify the main climate risk they faced, their impacts by identifying the level of risk based on risk checklist tables, and propose a set of questions that respond to the level of vulnerability of the healthcare facility. So these are where you can find these documents. So I'll leave it here because my 20 minutes are up. Thank you very much for your attention.
Thank you so much, Dr. Corvalán. A wonderful presentation, and we will certainly be able to explore in a little more depth during our Q&A. And just a reminder to all the participants, please put any questions you may have into the Q&A section of our of the Zoom platform. And there will be full information, biosketches, and also some accompanying documents on our webpage as indicated in the chat by the organizers. So now, without further ado, it's my pleasure to introduce Dr. Joy Shumaki-Guillermo, who is the lead for the office, the Joint Climate and Health Office between the World Health Organization and the World Meteorological Organization. And she will share with us new World Meteorological Organization directives on meteorological services for health. So over to you, Dr. Shumaki-Guillermo.
Right. So why do health professionals need to think about the weather and climate? Well, as we've already heard with climate change, extreme weather events are occurring more frequently and at higher magnitude all around the world. So we're seeing communities impacted on a regular basis, not by a single event, but often sequential and multiple events, sometimes even during a pandemic, that they need to be prepared for. So we just can't consider our preparedness for singular events, because often droughts, heat waves, and fires, they tend to come as a package. And so do cyclones, flooding, and heat waves. And the costs of these events and sequential stresses on water and sanitation infrastructure, on health facilities, as we've heard from Dr. Corvalon, can really be significant and cause major setbacks in health service access and delivery. But the positive thing is that most of these extreme weather events can be predicted many days and sometimes weeks in advance, and we know a lot about seasonal risk. Another reason that we need to be concerned about this is that the diseases that matter most in public health, such as dengue, cholera, meningitis, undernutrition, they are all strongly affected by temperature and humidity and other conditions that influence where and when these diseases are likely to occur. We also know that non-communicable diseases such as COPD, cardiovascular diseases, and even mental health are influenced by climate conditions. But the positive is that we have a lot of information about these climate conditions and how those conditions are changing season by season and year to year. And so if we're able to blend this knowledge about the climate, when it will start raining, when a drought will occur and how long it will last, with our expertise about public health, then we can have really powerful insights and intelligence about where and when diseases and problems are likely to occur and what kinds of stresses communities are going to be put under, so that we as public health professionals can reshuffle our resources to protect those most at risk. And the final reason we need to think about this is that climate change on a longer term time scale, decades ahead, is that climate change is not only amplifying extreme weather events, but also accelerating environmental degradation and complex health risks like urban heat islands. And so positively, we are also able to use climate projections, which are increasingly robust and powerful because we understand the physics of the oceans and the atmosphere and what that's going to mean for future temperatures, for sea level rise. We have this opportunity available to us. And I would be remiss to also not mention that climate change solutions are also visible on the horizon. And we know what policies can work and mitigate climate change, but also be protective for public health. So it is to say we have a lot of intelligence about the changing climate, how it affects us, may drive diseases, stress health systems, but why aren't we using this information more readily? Well, the first reason is that the health sector doesn't monitor the climate. This information comes from outside our sector, and we don't have the access to the information that is readily packaged for us to use. The second reason is that we in public health are trained in epidemiology, not climatology. And so we don't have a good understanding of where this data and information comes from, how it's used, how good it is, how to read charts like these and interpret them to know how it might be affecting a health risk at a local level. So to be able to unlock this potential, we have to have partnerships with climate experts who can help us navigate and bring together health informatics with climate informatics in much more interoperable ways. And so the way to do this is through climate services, which are generically described as partnerships or processes that can bring together our intelligence to produce fit for purpose and relevant information about the weather, what's going to happen on a day-to-day basis like heat waves or storms, the climate, what we can expect on a seasonal and year-to-year basis, how those extremes may change over time. And also climate services provide analytics on the trends and impacts that weather and climate is likely to bring. So what are some of the common applications, how we use this knowledge? Well, first and foremost, it starts with historical analyses. How are diseases and health outcomes sensitive to climate and weather conditions, such as this analysis of diarrheal diseases and rainfall in Peru? Increasingly, we are seeing climate information used for the evaluation of health service and intervention performance. So did malaria go down because you distributed bed nets in the right communities at the right time? Or did it go down because you're operating in an extended drought period and it probably would have gone down anyway? So it's important to have this kind of historical climate information so that we control whether the weather is working for you or against you in your interventions, and ultimately is money being well spent or wasted. The next set of tools that are very powerful and increasingly used is for risk monitoring. Because once we know the sensitivity of a disease to climate conditions, then we can rather easily monitor and even predict if those weather conditions are going to create suitable environments for the diseases to be transmitted, like this tool looking at climate suitability of malaria in Madagascar, or the E3 network that is used by the European CDC to merge information about the climate, environmental risks, and health outcomes. And finally, climate services can also be used to monitor air pollution, air-related concerns, such as, which way is the wind blowing? Is the air pollution becoming toxic in a city due to increased temperatures? These are pretty pertinent questions to be able to answer. Finally, probably the most known climate service are focused on early warning systems, because even though early warning systems might take time to establish and maintain, we know that they save lives. And they can also not only alert the public to hazardous conditions and what needs to be done, but they can help health facilities start to plan and prepare for the kind of patients that they might be seeing. And finally, climate change projections are really useful for things like Dr. Corvalon was speaking about. How do we plan our health facilities to be prepared for future climate conditions? So these types of tools and analytics are really what we need to start using in a more regularized way to become smarter, better understand these risks that climate change is introducing to the issues that we're already dealing with, and help us think across timescales and across multiple hazards. So how do we get started in doing this? Well, it starts with the National Meteorological and Hydrological Services. And Met Services are really essential agencies. They run 24/7 operations, and they're not very well known. They're mostly known for one of their most popular products, the daily weather forecast. But the Met Services actually do a lot more than this. And perhaps one of their most important roles is in observing and monitoring the local atmospheric conditions, and then transmitting that information internationally and nationally into data centers where it can be processed and aggregated and develop the global climate and weather models that allow us to predict what's coming. So the National Met Services are really critical to what I like to think of as a real-time global surveillance system tracking the pulse of the planet. And only through standardized measurement and aggregation of 52 essential variables of the oceans, the atmosphere, hydrology, that the Met Services are collecting data on, can we start to understand how Earth systems work and how the climate is changing. So you can also start to see where coordination is pretty essential. And this is where the World Meteorological Organization comes in. The WMO is able to bring countries together and set the standards for how those measurements are taken, how they're collected, processed, and then applied with climate services. So without this coordination and without the coming together of this data, we would not have the predictive capabilities and the intelligence that we do today about how the climate is changing. So if we can start to harness this information about climate and weather and incorporate it into how we do business in public health, I strongly believe we're going to be on the path towards more resilient health systems. There are a broad range of applications that are programmatic, operational, and policy decisions that can benefit from this kind of intelligence about what is happening in the climate and to the risk factors that we're dealing with. So unfortunately, one of the other reasons that we're not yet taking full advantage of climate services is that they're really underdeveloped. And the WMO tracks the availability of climate services. And we see that actually less than 40 countries in the world have developed the type of partnerships required to develop the analytics and intelligence between the Met services and the health community to start to really inform planning preparedness across different timescales. And this is one of the reasons that the WMO and the WHO have intensified their collaboration over the last decade. Right now, we have a new 5-year strategy that's helping us focus on catalytic activities that can build capacity, build the partnerships, develop guidance on how do we further catalyze this available science, get it into application and use, addressing the key questions that health systems, health policymakers are asking about what climate is going to do to their budgets, to their staffing needs, to their health infrastructure, to all of those components that Dr. Corvalon just referred to. And we are working towards a longer term strategy of normalizing how this information becomes available to the health community, how it is used through standardized mechanisms and instruments for climate services for health. And so I'll just end with this quote that I love from the former Director General, Dr. Margaret Chan of WHO, who said many years ago that climate services can be a new type of health service. They can improve the effectiveness of our core business in detecting disease, monitoring health risks, anticipating problems, and taking action to save lives. So thank you again for listening, and apologies for the technical issues.
Thank you very much, Dr. Guillaume. Thank you for showing such personal and systemic resilience of your own in dealing with that sound shock that we were dealing with. And if I could invite back Dr. Corvalon, please, you can turn on your video as well. We encourage the participants again to ask questions in the Q&A. But I'll start off, and I'll start off with a question for Dr. Corvalon, which is, and thank you both for really outstanding presentations and for the outstanding work you were both doing in helping to transform health systems in the way they need to be transformed for a setting of climate change. So Dr. Corvalon, thinking about, you mentioned the need to prioritize the interventions. Obviously, if there are unlimited resources, we could make health systems redundant and resilient and able to cope with anything, but our resources are very limited. For something like hurricanes or storms and floods, what would you say are some of the most common failure points or tipping points for a health system, and what might be the highest priority things for a health system to look at if they're in a flood-prone or hurricane-prone area?
John, I think that you are addressing the most difficult part of the work, is having to pick and choose where you invest. Because the problem is that when we identify these 4 key areas, which are, first of all, the health workforce, then the water, sanitation, and the healthcare waste, then the energy, and then the infrastructure and everything that goes around it. It's very hard to say, well, what is it? Do I want a solid infrastructure, but the water and sanitation could fail, or my energy is less reliable? And the truth is that you need to have everything. And this is perhaps what is most difficult for less developed countries and poorer areas in other countries in which the healthcare facilities have the bare minimum. So we know of places, many places, that water sanitation services are not available for a great time in a healthcare facility. So you would say, well, the first thing that you need to do is to provide that. Or a healthcare facility that functions with having electricity a few hours a day, or they only have a generator, but they don't have the fuel or the solar panels to run it, to run the electricity. So these are the first things that you need to do. But we cannot also forget about the workforce. If you don't have a well-trained workforce, motivated, informed, then nothing of what I'm saying will work. So it is difficult, but we really need to think small, but everything at the same time. We cannot do everything. We cannot have the best energy system or the best infrastructure. We need the bare minimum, but we need to address all of them.
Thank you. Yeah, that's a very, very wise answer. Dr. Guillermo, so that was a wonderful presentation, and you've kind of laid out a whole set of resources and capabilities that are becoming available to a health service. But if I'm listening in and I'm either in a large health system in a country, or I work in a health ministry in a country that really has not thought about this very much before, hasn't had the opportunity to connect, what might be the first steps for somebody listening? Is it personal training? Is it starting a conversation? Is it doing a needs assessment? What are some of the first steps for getting going in the use of climate services for a health system?
Right, it's a great question. So, John, there's often a lot of activities focused on climate change, which are occurring in a prime minister's office, in an environment agency, in an agricultural agency, that are likely disconnected from what's happening in the health sector. And so, one of the first steps is to do some research and figure out who is working on climate change in my country. There are national policies, there are coordination mechanisms, there are reports about what is happening locally. And that's the place to start. Find out who are your experts and what is happening in your country, what's already known. And then the second thing I think is about capacity. It is starting to learn about how climate is influencing health in your own country. What are the solutions through some of these toolkits that Dr. Corvalon has referred to? There are a lot of resources out there and available that can go a long way in starting to understand what are the major priorities in a country. And then depending on the role that you play, you may be able to develop a national vulnerability and adaptation assessment process. Or you may get involved with some local NGOs in community-based activities in raising awareness for the most serious extreme weather events in your country. Is it heat waves? Is it coastal flooding? There are lots of actors who are already concerned and motivated to take action on climate preparedness.
Great, thank you very much. I have many more questions that I could ask, but I think we need to move on, and I think we will come back to some of the issues that you started to raise. Especially, I want to talk about the workforce issue, but we'll have the opportunity to do it perhaps in a more experiential and in a group manner at the end of our session today. But for now, we'll transition over to the second session. So again, Dr. Corvalon, Dr. Guillermo, thank you so much. Those were wonderful presentations. I really enjoyed them very much. And we will move on to the second half, which will be hearing from some folks who are in the field, who are experiencing the need to respond to COVID-19 and to natural disasters at the same time, and hear their personal experiences. Our first speaker will be Ms. Sujata Saunik. Ms. Saunik is the additional Chief Secretary in the General Administration Department for the Government of Maharashtra, India, and Secretary Saunik was previously an additional Chief Secretary in the Health Department, which is where we came to know each other. And I've asked Secretary Saunik to speak to us about now her experiences from the disaster management and health administration side in Maharashtra. So Secretary Saunik, I turn it over to you.
Thank you so much, Dr. Balbus. It's always a pleasure to be with you on a panel, especially all the esteemed panelists who are joining today. And I'm happy to share the vignettes from the field, as I would like to call them, from Mumbai, Maharashtra in India. I have just a couple of slides and then I will sum it all up in the time that I have. So in my first slide, which is the next one, what I would like to show you is a timeline about what was happening in late February and early March in Mumbai and in Maharashtra. So on the left side, there are just a few statistics about Maharashtra. And on the right side, we have the timeline. We had just the newly elected government coming in November 2019. And as you can see, that we also had the first COVID case reported in Maharashtra on March 11, 2020, which is also the day that the WHO declared coronavirus as a pandemic. It happened on the same day. Although the first COVID case came to India earlier than that, but that's when Maharashtra got it. And very soon after that, within 10 days, we had our first lockdown on March 22nd, and then we had a countrywide lockdown on March 25th. And Dharavi, which is one of the biggest slums in Asia and indeed in Mumbai, also reported its first case on April 1, 2020. So while the new government was just settling down, we were in trying to get the budget passed in late February, early March. We were already in the midst of facing a pandemic. And close on the heels of this, a couple of months down the line, on 2nd of June, we had the Nisarga cyclone entering the coastal regions of Maharashtra. And by 7th of June, the Maharashtra's tally alone was higher than that of China. So you can just imagine the scale at which the pandemic hit us and what exactly we were tasked with at that moment. So in my next slide, what I want to show is just a sense of what we felt at that time. Between April to June, it was really a very testing period for the state and the state's machinery. And in the next slide, I am trying to show a little bit information on Nisarg, which has been one of the most severe cyclones the state has faced in the last century. It made landfall about 62 miles from Mumbai. Mumbai faced high velocity winds, but it's the coastline which suffered the worst impact, including neighboring areas. And interestingly, Nisarg caused immense damage to external buildings which were not the natural habitat of that region, the buildings which were the traditional housing of that area survived the damage. So I'll come back to this point later. And so you can see that we had a double impact of two very, very serious climatic events and a public health emergency happening at the same time. So how did we deal with it? So the impact in three main sectors was in public health. I think the most important thing was it brought to fore the shortcomings of our system. When in regular peacetime, we are not in a position to provide healthcare at a level at which it's expected, simply that we spend less than 1% of our GDP on public healthcare, that we didn't have enough number of beds, and that we had more people wanting to be hospitalized than we had beds in the hospital. And all of those issues meant that it became also so much societal in the way we were dealing with this. How do you inform the citizens that they need to play their part and take ownership of personal hygiene? How do you create social distancing in a densely populated area? How do you provide for basic things like PPEs and masks? And you ramp up to a scale that was important at that time. So lack of awareness of basic hygienic practices, building an efficient ambulance system, bringing to fore treatment protocols, and also just not having enough human resource to deploy meant that the situation became even more difficult. Those were very difficult months. The economic impact was that India's economy contracted by 23.9%, and one of the biggest contraction was seen by Maharashtra. And it has 5 districts which were in the worst affected districts in the country. And except agriculture, all core sectors suffered because we had also a lot of migrant movement, people losing their livelihoods, and just simply everything shutting down. In the environment side, though, it was very interesting to see what was happening. You suddenly had the best air quality you had seen in years. You had cleaner water in the riverways, and Nisarg contributed to that in a big way. The backwater that came in, it brought significant improvement in the water quality of the water bodies. And we also had, so many heartwarming stories of when the people were locked inside their homes, there were the wild animals roaming on the roads and streets of our state, including tigers and cheetahs. They were all out, So that was the kind of impact that and Nisarg and the lockdown brought together. So what was the approach that we had taken? Of course, the first was containment and lockdown and screening, and then trying to ramp up the facilities in the hospitals as quickly as we could, improving our testing capacity, so to be able to test people who were having symptoms, and then moving on to a phase which was more of active search and screening, especially in the slum areas. And Dharavi is a story which has been very well documented, where this kind of work was done, and setting up local fever clinics and bringing basically public health closer to the people, and then doing a house-to-house survey and making sure that the drugs and the human resource are available in the public health facilities, and also roping in the private health facilities to play their role. Using of technology, and I'm very happy to say that we also used data analytics to provide ward level strategies and to improve the operations of the government run operations. We took support from groups like the Boston Consulting Group and others who worked with us pro bono to help us set systems in place, processes in place. And then we also tried very hard to onboard skilled manpower quickly on contract jobs so that they could fill the human resource gap. And participation of the industry. Mumbai is the financial capital of India, and all the industry presence in this state, they all came forward in a big way. Wadias, Godrej, the Indian Oil, ONGC, all these major players, they all came forward to support the government action. And all of us in the government were given additional tasks that still continues. And we also brought in the NDRF to support us. So what have we learned in all this? What we learned is that it's so important during peacetime to invest in capacity building, in disaster risk reduction measures, in learning from the way the events have unfolded, and making tomorrow more prepared to handle something like this. And it's so important that India really seriously takes the kind of extreme climatic events that it's facing. There's a recent report that has just come out by the Center of Energy, Environment and Water. It was released on 11th of December, which says that India is not only facing extreme climatic events, but there is a sort of a role reversal. So areas which were facing floods are now facing droughts. And at the same time, the same areas are probably different parts of the same area are facing both the events at the same time. So this is this is really a wake-up call for us to invest better in disaster risk reduction measures. I think I'll stop here, and I'll be very happy to clarify anything that I've said or throw more light on what we did. Thank you so much.
Well, thank you so much, Secretary Sanik. Wonderful opening set of comments, and we will definitely look forward to further discussion. Quick reminders again, please put any questions you may have as a participant in the Q&A box. And for full bio sketches, you can go to the website for our webinar. But for now, it's my great pleasure to introduce our next speaker, Ms. Antonia Loizaga, who is a trustee of the Manila Observatory in the Philippines and a long history of working on climate change adaptation, disaster risk reduction in that area. I turn it over to you now, Ms. Loizaga.
Yes, good evening and good morning and good afternoon to everyone. Thank you very much, John. I'd like to begin by sharing this picture. This is an image that is typical of our evacuation centers. Very recently, the country was hit by 3 successive storms, basically, some of which were really quite intense. And all of the 3 storms that we were hit with, the typhoons, if you will, struck us within 11 days. And the areas that were hit by these typhoons were largely the same areas for the 3 different systems. So We are, as you can see, facing a crisis in terms of public health, as well as in terms of a weather-related hazard. In the Philippines, hazards are changing, largely due to the impacts of climate change, but also exposure and vulnerability have been changing. Population growth, urbanization, these are all fairly well-known trends. And I'd just like to share this image where you see that in the last 20 years, the Philippines ranks fourth in terms of the countries in the world that have been impacted by disasters. We need to understand exposure and vulnerability as they are differentiated across income groups and environments. And the hazards that in fact outnumber all others are hydrometeorological in nature. So really understanding risk as the combined effect of hazard exposure vulnerability, particularly for hydrometeorological and climate-related hazards, has been a challenge for us. In terms of our long-term climate, we now are looking at the potential for heat risk. 40% of population has now been affected as well. And we're looking at 2 degrees in the mid-century in terms of increased temperatures. Low-lying areas will be hit by a very high level of sea level rise, sometimes twice the global average in some areas of the Philippines. Our systems, as you have heard in the previous examples, in terms of healthcare and health service delivery, have been overwhelmed, not just by these weather-related hazards, but certainly by COVID-19. Urbanization, informal settlements, our different geographic locations. We are 7,100 islands. There are geographically isolated and disadvantaged populations. These have all put stress historically on availability, access, and affordability of health services. COVID-19 has exposed these gaps more deeply, and we now understand that our infrastructures, our technical and human resources, our equipment were largely short. And in fact, at the end of the day, we were struggling, as you heard in the previous example in India, with just basic PPEs, RT-PCR kits, laboratories to process our affected. The response of the Philippine government, and I should say that they have taken on international consultants as well, has really been to look at these impacts of both climate and weather, as well as COVID, and capitalize or leverage capacities that are built through innovative partnerships that have existed over time. I cite here one particular example, which is a partnership between the Department of Health, USAID, and a private sector foundation, the Zwilling Family Foundation, essentially set up to build capacity in terms of health change models, leadership and governance for the containment of tuberculosis, for maternal and child care, for reproductive health care for adolescents. What was done was they leveraged the infrastructure and the leadership and governance skills to actually deal with COVID-19. And that infrastructure that was in place to deal with those other issues really became a system in place. You see there, DRRMH, that's Disaster Risk Reduction Management Health Plan, in local government units. It became a referral system for cases. It established testing, healthcare, and quarantine facilities in the barangays, the smallest political units. An information and communication system was capitalized on to actually begin to bring data where it was needed most, and to establish clear roles among the stakeholders. This was a multi-stakeholder partnership with the help of an international development organization working through the DOH and the private sector, and directly down all the way to the lowest decision-making level, which is really the barangay, the village level. The clear objectives in place, and this is an ongoing project, really were to look at preventing local transmission, preventing overwhelming the hospitals. But I should say that originally this program, as it was designed, was also investing in climate risk of the facilities and the service delivery networks that were being put in place for these other types of issues. We capitalized on what was put in place and then used that in order to deal with COVID-19. Another response that was also worked on was to build evidence-informed risk governance very quickly using data and analytics, but making this actually spatial and temporal at the same time. And then beginning to integrate the healthcare facilities and the COVID data with multiple hazards. And there is work now ongoing with incorporating data from weather stations, earthquake early warning instruments onto these types of dashboards. We are working with universities, we are working with local governments, with the departments of health and their representatives at the local level to begin to build this type of integrated analysis in terms of risk to both COVID and other natural hazards. Weather, of course, is one of the main challenges. And you see here in this particular blue areas, these are flood footprints of the result of major typhoons that have hit the city, Cagayan de Oro City. We're working with cities and provinces now to construct these databases in order for them to track both the spread of COVID-19, the treatment and the testing and recovery, as well as the risk to other natural hazards. The other response has really been to begin investing in prevention. Climate disaster and disaster risk assessments have become a basic exercise for the local governments that we work with. And here we see not just a hazard being looked at, but also social vulnerability and trying to build around that type of integrated assessment. Social in terms of the vulnerability, the flood susceptibility of areas, the facilities that are needed in order to actually sustain evacuation. This type of integration of data and the analytics involved are already ongoing. What is a challenge for us at this point, and I should say this, is really access to high resolution climate projections across multiple scenarios. We now have the 25 by 25, but we would really like to have access to five square kilometer type projections and timely access in order for these, in fact, to be incorporated into the climate and disaster risk assessments, looking at the near future and of course, the medium and longer term. My last point here would be for us to begin to work on finding value in the collaboration between the WMO and the WHO within a resilience framework, and this has been mentioned before, but really employing a whole of society approach, looking at human development as a cornerstone and pillar of resilience, and health being a critical foundation for human development. And here's where we would like to point out that all of these issues are interrelated. We cannot look at health and climate without looking at everything else in the society, and leadership and governance being the key in order to achieve the kind of impacts that we want. So on that note, I'd like to close my presentation. Thank you very much, John.
Thank you so much, Antonia. That was wonderful. Very beautiful slides, beautiful work being done there. Very much representative of the conversation that we had in the first session. And I'm very eager for our discussion after our next speaker to return back to it. But without further ado, let me introduce Dr. Aubrey Miller, who is the Senior Medical Advisor in the Office of the Director of the National Institute of Environmental Health Sciences. And Dr. Miller will be speaking to us about ways to facilitate research in the midst of the chaos we have lived in 2020 to be able to help build best practices and build the evidence base on a local and a larger scale. So over to you, Dr. Miller.
Thank you, and I'm honored to be here this morning, afternoon, evening, wherever you might be, to talk to you a little bit about building the evidence base, picking up from the former discussions in ways to apply it to not only disaster risk reduction, but system resilience throughout. The timeline below in the slide here, shows that, in a sense, disasters are fairly predictable. We just need to determine the location and timing of when they will occur. So essentially, we can be prepared and we can begin to move forward and build the evidence base that is needed. The Sendai framework, which includes health, really focuses on understanding disaster risk. and disaster risk in all of its dimensions, and trying to understand the evidence base that we'll need to understand vulnerability, capacity, exposure of persons and their assets, the hazard characteristics, and the environment. And being able to do this across local, national, regional, and international venues. And as the previous speakers had talked about it, it's really about thinking through what is the information that we need to collect, who are the partners we need to form, how do we come together to get that information creatively and effectively. The vital health indicators within the Sendai framework allow us to think this through a little more thoroughly in a way to start to break this down. So one of the indicators to think about is temporality, the death and illnesses over time. So not only if you look at the picture on the right, which shows the acute response, the tip of the iceberg, and the time frame below, which is the longer time frame of recovery, where much of the information is missed all the time. But that information is vitally important to understanding and beginning to move forward with our future preparedness and sustainability. Understanding attribution, linking the deaths and illnesses to the various factors and related causes and what that entails in terms of information. Understanding baselines, as was mentioned earlier, in understanding not only the meteorological baselines, but other types of baselines of infection and disease throughout, so we can begin to understand the perturbations in those baselines, and if our measures, our preventive measures, our mitigations and treatments are effective, and be able to make comparisons. The hazard classification, really developing methods and models to assess the exposures, risks, and vulnerabilities, and having standardized taxonomies to be able to make comparisons across studies and across regions. And then thinking about the thresholds of which trigger our data collection, trigger some of the systems to go into play, and how we begin to implement those going forward. So I wanted to really us to think about how do we begin to operationalize the framework to the real world. There's been a number of efforts for the scientific community and calls for this throughout the years. Most recently was one by the National Academies of Science that was funded by the CDC to look at the science base for public health practice in the United States in response to disasters, and found that it was woefully inadequate, that our ability to respond, while that has been strengthened over the years and is effective in many ways, our ability to actually capture meaningful data that allows us to translate it to effective public health practices and changes in sustainability and resilience is woefully inadequate. I highlight the bottom two things in the boxes there in terms of reports that allow us to understand and have built forward in terms of our NIH program, and one being a National Academies report for your further information. Despite its importance, disaster research is typically delayed or missed. As I was noting, there's just no formal way to coordinate the research across multiple entities effectively, especially between health departments and academics. It's difficult to fund the research. Issues related to IRB and the ethical conduct of research, lack of ready-to-go tools and protocols, lack of trained researchers to gather the data effectively in place, like we're seeing with COVID and the lockdowns, and how to get out and be able to effectively collect information. Lack of inclusion of community stakeholders as part of the process and understanding what their needs are and their concerns and translating that and the information back to our stakeholders. And the exposure data is typically missing. We have developed a program within NIH, which allows us to improve the processes and infrastructure for research. And this program really is developed to focus on these kind of boxes here to increase the speed and quality of epidemiological and clinical research and promote standard measures by identifying research priorities, by implementing research more effectively with differing tools, by empowering research and improving the research processes such as IRBs, by training, and by engagement and coordination of multiple actors, including other nations. We now have program partnerships with Canada and Japan to develop what we call the NIH Public Health Emergency and Disaster Research Response Program. As part of the effort, we've been trying to make the survey instruments more readily available to the research community, including metadata about those research instruments. There's typically right now over 425. We now hold the NIH COVID-19 collection, which has almost 100 survey instruments related to COVID-19, as well as full-blown protocols that allow researchers to kind of take them and use them in different ways of standardized instruments. It would have consent forms and medical testing, and these have been IRB and peer review that can then be modified for differing situations and used and implemented. We've been having training workshops throughout the country. And these include large groups of participants, federal, state, local agencies, academics, public health industry, and community organizations to explore the local capacity for research, needed partnerships, implementation challenges, and community engagement. And to facilitate the engagement between the researchers and agencies and identification of the research needs, new research collaborations and networking, and the clinical and environmental data collection efforts, trying to think through how we may be able to effectively come together to collect information. And additionally, we've been working to speed up the ability for IRB and ethical considerations in research. And we've been having mock workshops with IRBs and academics as part of these larger scale workshops based on scenarios, and trying to improve the capacity of the IRBs to get out into the field quickly. And then these have come together with actual disasters now. So we started to have these workshops initially just to train and see if we could learn and speed up our ability to collect data and information together collectively. And now in response to the Hurricane Harvey incident in 2017 and the COVID crisis now that we're in, academic institutions have partnered with public health agencies and other groups to form rapid collaborations and begin to collect data. Which would typically take months, and now doing it in days to weeks and collecting, whether it's environmental sampling, which was here in the picture of Hurricane Harvey, with GIS mapping and data and rapid registries is called upon in the Sendai framework, or the application for COVID-19 with rapid research collaborations across departments and public health agencies at the University of Arizona. So with that, I'll leave you with the last slide about trying to build the evidence base of global health practice using expertise skills, the empowerment of data collection and reporting guidelines with communities, training of our diverse stakeholders through curricula, exercises, and centers of excellence, and then translating this to public health practice, mitigation treatments, resilience, and sustainability through our abilities to, more importantly, think about the process and putting ourselves in a position to collect information effectively, quickly going forward. And with that, I'll look forward to our discussion. And thank you, John.
Wonderful. Thank you so much, Dr. Miller. And this, in some ways, you may have seemed like the odd person out in that you are talking about research and representing a research institution and everybody else is in the practice field. But I think you very clearly demonstrated the logic and why you were so valuable to this session and how this paradigm and resource for research that you have created actually can be an intimate part of preparedness, of building resilience, of building the human relationships through the training workshops, in addition to building the evidence base for best practices and for resilience. So thank you for demonstrating that in a very short period of time. We have questions coming in the Q&A. I'm just going to start off with a question, and if Ms. Sanik and Ms. Lozaga could turn on their videos and join us. I wanted to just start with a question. Both of you told the stories of such extreme challenges that your country's faced, as did the United States this year, of not just one severe storm, but multiple severe storms in close succession hitting the same areas while people were facing the pandemic. And I just wanted to ask if you could reflect on how this really almost, historical, if not unprecedented level of stress on our society has affected people and politics in your countries. Has it changed, and just some things to think about, has it changed the political will for investment in preparedness? Has it changed people's feelings about the role of science, which has been certainly a big issue in the United States? And how has it affected, this level of stress and repeated stress has affected the resilience of the communities and their willingness to continue to comply with difficult public health measures? Any comments in those areas?
I can go first if it's okay.
Okay.
Okay, so yes, it has had a deep impact simply because in this period that there has been a lockdown and a slowdown, the only thing that the government was tasked to do was to provide a sensible response to the pandemic. And so right from the highest levels, our Prime Minister himself and then our chief ministers, many people would have read about the kind of work Kerala's health minister did, and how resources were diverted and how quickly the facilities were ramped up. All of that has brought to fore the need to the political leadership that unless they invest adequately in health and education, such disasters, if they happen again or continue, as we at least know today that we are not over it, it's still around us. They have understood that it's going to be very, very difficult. So there has been support at the highest level, I would say. The shortcoming, though, is that we have technical institutes who should actually be partnering government in these activities, but they're overwhelmed. And you also need such institutes to work closer to the state governments. Everything can't be at the national level. So just as Aubrey was showing today that, disaster resilience doesn't just happen at one level, it happens at multiple levels. So one thing that has come to fore is that whether it's a municipal area or it's a village panchayat or it's a city administration, there have to be technical institutions, scientific research organizations which have capacity to work alongside the policymaker and the policy implementer and provide adequate inputs to the political leadership. I think that's the biggest learning.
Thank you.
Thank you.
Thank you, John. I think of all the biggest changes that we have seen in the very recent months has been the call for more science in decision making. And COVID in particular has driven a call for transparency in terms of the actual counts and the way resources are being spent. That has helped, I think, disaster risk reduction overall, because the call for more science really means the call for more evidence, and the less politics will have to do with the way decisions are being made, particularly at the local level. The second lesson that we're seeing here now is the role of universities, and that was mentioned by Mr. Jaza earlier. The realization that universities and academia in general need to be part of the decision-making process. And that has led to calls for inclusion in terms of the different representatives from academia in the debate as to how to reduce disaster risk and to deal with the COVID crisis. On vulnerability and exposure, unfortunately, the latest data from our own government is that nationally, COVID-19 and the lockdown has led to 2 million more people being plunged into poverty. And that means 2 million more earning less than $3.20 a day. That kind of vulnerability, when combined with natural hazards, just leads to a decreased capacity to cope and recover. And so special intervention will need to be done in terms of these new population that is, it's fallen below the poverty line. I think the final 2 points I'd like to make are really the new role for the private sector. We've just finished a mission, for example, we're in a Catanduanes Island, which is the first island to be hit by the last systems, was virtually isolated. And what had happened there is no one knew what the real damage was. So the private sector, together with civil society, actually deployed a damage assessment mission using aerial surveys and also a deployment of communications technology. And I would like to stress this in part because we look at health centers as needing water, as needing energy, but we also need to look at them as needing communications and the capacity to actually relay to authorities what the needs are is really what the critical use is for having very agile and very robust communication system for health centers. So I think that the private sector's role has been emphasized. The role of academe has now been renewed and looked at as part of the decision-making process, and the call for more science. And I think that's one of the most beneficial impacts, if you might call it that, of these combined crises. Thank you.
Wonderful. Thank you very much.
I'd like to pick
Sure.
up on something that Antonia said. Yeah, and really, you know, while our model in the States has been one of kind of a centralized model with the federal government leading the disaster management side of the house, then with the states and locals. In terms of the disaster research and science, that model does not work well. And I think it really is about how to flip this and then incorporate the local academics and other partners at a much more effective and comprehensive level to be able to collect the scientific information we need. The health departments don't have the capacity to do the research. From the centralized organizations like CDC and others, they really don't have the capacity to do that on the wide scales that we're seeing as well. And we really need to think about creativity of using our science base and our investments and our research enterprise across our countries and across the world much more effectively, like a fabric that can bend and flex and help each other. How do we bring the expertise from the States to India, from other places quickly and in a seamless way to allow those skill sets to come into play, whether it's an understanding of hurricanes or an understanding of wildfires or et cetera, and be able to allow that expertise to participate and to contribute. And what we're seeing, and I didn't have much time to explore it, but the models that we're starting to see now being led by universities in partnership with local health departments, with private sector, and including emergency management, understanding, coming together ahead of time and talking it through and then applying some of this has been really interesting to me. And one other thing that's come out that I just wanted to comment on recently, and this was so effectively discussed a little bit this morning in the World Meteorological, is about our geoscience agencies really leaning forward now and trying to make data available to the health community. They're essentially imploring us to come and use geoscience, geospatial atmospheric science data much more so. And I think the hand is out. The health community really needs to work hard now to grab that hand and to do more so we can actually move forward on the resilience and the climate change understanding of risk factors that we need.
Great, thank you so much. And Ms. Lizaga showed some great slides of great geoscience agencies. Must have provided some of those maps. We are pretty much out of time. I'm going to take a risk here, ask everybody to turn on their cameras and ask each of our speakers to just reflect on in one or two sentences on something that all of you have just touched on, and which our one question, the Q&A, has also touched on. We've gone, we started very top down at the international UN agency level. And then we've heard about a little bit of the bottom up and about, what's going on in the neighborhoods and the whole initiative with the local government and the Bagayans, I think they're called in the Philippines, to mobilize and to engage communities and governance at a more local level. So if you could, I'm just going to have you go in the order that you spoke no more than 2 sentences because we are just about out of time, but the best way to connect top down and bottom up, or even how do we build up the capacity to meet the top? So I'll stop there and start with you, Dr. Corvalon. Your thoughts on that?
Okay, thank you, Dr. Balbus. And you remind me of something really important, which answers your questions in a way, which is WHO produced what is called the Manifesto for a Healthy Recovery from COVID-19. I have just pasted the information there, but what it's really saying is that we need to do things differently in everything we do. So when I was showing the slide about resilience, the best way to do things is not to go back to the way we were, not to go back better than the way we were, but to transform the system somehow so that we don't suffer the same problems over and over again, which is the question that one of our participants is asking in the chat.
Asked, yes.
Thank you.
Okay, thank you. On to Joy.
I
agree.
I think we've heard today how interconnected and cascading all of these issues are. And I think each of us can take steps to improve our anticipatory thinking and do that by partnering widely, getting out of our silos and drawing upon the available science, the learning that is out there about how to manage these hazards and help us think more creatively about the solutions that are going to be needed from the bottom up, as well as those long-term policy solutions.
Thank you. Sujata?
What I would like to say here is that in our country, what works best is, both the bottom up and the top down approach, because it's such a diverse country. There are so many issues and they are at scale. So one approach will not work. And the biggest learning in the last few months is that the more information is provided at the cutting edge, the local leaders, your ward, corporators and your village panchayats, the more easily information is given to them, the better it is for the community, because they are the community leaders who will take that information to the people. The governments are too far away from the citizens at large. So that's one very big takeaway. And the second thing that we saw happen, and it's very encouraging, for the first time in this country, we saw that all the private sector geared up together and came forward to support without keeping profit as a motive, which was very encouraging. I think this you see in the developed world. You don't see it very often in the developing or recently developed world, to be correct. So you find that that kind of a push that came from the industry, and we saw startups, young startups, coming forward with technological solutions. That was very, very encouraging, and that's what's going to take this forward.
Thank you. Thank you very much. Antonia?
Thank you, John. I think just a couple of points. This is a whole of society effort. There is no one or two basically sectors just taking the lead here. This must be whole of society. The special roles of academia, I think today, in terms of moving science to action and looking at transdisciplinary work rather than just interdisciplinary or multidisciplinary work traditionally found in academic silos. The kind of transdisciplinary work that involves practitioners, communities. This is what is needed to understand where risk actually begins, which is local. Locally is where risk actually begins. And that's where we need to be looking at in terms of bringing people together. And finally, the role of the private sector. It is time for the private sector to not just be a donor. It is time for the private sector to be a co-implementer with government and with local and national governments, as well as civil society. And the only way they can do that is to embed risk reduction into their core business value cycles and not make it an option for corporate social responsibility. It must be embedded in core business value cycles in order for it to make a difference in terms of climate change and in terms of disaster risk reduction. Thank you.
Thank you. That sounds like a seed of transformation right there. Over to you, Aubrey.
Yeah, and thank you, John, and thanks to everybody for being part of this great discussion. And I just want to add on to Antonio comments a bit. We practice disaster management. we don't practice disaster risk reduction in the science side of the house. And I think that's what we really need to be doing. And we need to do that ahead of time. We need to think through the data, the questions that we want to answer, the data that will be required, who's involved to collect that information, what do those relationships look like, where will the data go, how do we involve those community partnerships effectively to make sure they're at the table, we understand their concerns, and we're able to disseminate the information back to our stakeholders effectively. I think that's the big change for me is we've been practicing all the other stuff, and now we need to practice our science in this in throughout. It's these situations happen, and we go and we respond to them, and we learn all sorts of things, and they go into these after action reports or somewhere, and we lose it, and we don't, and then we move on. So we need to really make this as much of a operation like we do with our disaster management as we do with our disaster science. And that would be my final comment.
Wonderful, wonderful last comment. The message, the goal, the beauty of the Sendai framework. With that, please join me in thanking our speakers, our panelists. That was 5 wonderful presentations, wonderful discussion. You have all done such an excellent job in elucidating this intersection in this topic. I'm very, very grateful to you. So a virtual round of applause to you all. Thank you so much.